disorder. Many doctors, hospitals, nurses, healthcare organizations. And we used to tell doctors that you need to overdo everything. You need to make sure that that history of that patient shows that you went way beyond the standard of practice in the community, so that if you ever did get sued, you would at least say, we went way beyond what really the average doctor would have done. In the process, I became convinced that unnecessary defensive medicine, we all want necessary defensive medicine, but unnecessary defensive medicine is extremely costly. And yet, if I was a doctor today, I'd be doing exactly what my advice was 37 years ago, and really doing everything I possibly can. I don't expect you to opine on what it's costing the healthcare profession just for unnecessary defensive medicine, but it's a whopping amount of money, a lot more than the CBO says. I remember the CBO said $10 billion a year. I chatted with them, he finally came up with around $50 billion a year, but I think it's approaching $200 or $300 billion a year when you consider how healthcare is so important in our lives today. And a lot of that is because we just can't seem in the Congress to resolve this issue so the doctors can handle it. Now, I would like each of you to give some thought. I've really enjoyed your comments here today, but I'd like each of you to give some thought and maybe even send in writing to us what we might do. You've got Democrats who don't want to defend their personal injury lawyers. You've got Republicans who don't think there's ever been any reason to sue for medical liability. Not many, but there's some. And I mean, you got the two extremes, in other words. And it'd be wonderful for us to get, especially from the American Medical Association, but from each of your groups, just what you think is really unnecessarily costing our society because of medical liability concerns. I'd like to have you take the time and send that to me, if you will, but certainly to the committee. Let me just ask one other question, because interestingly, we hear about the death of private practice today. Indeed, many experts who track the health sector have raised concerns about the uptick in hospital acquisitions of private practice. And this is for any of you who care to answer. Do you believe hospital acquisitions are occurring at a greater rate? And if so, what is causing the trend, and is it likely to continue? And what are the implications for the cost of care in the Medicare programs? Yes, ma'am.
Senator Hatch, I think you've hit the nail right on the head. I know that in 2010, about a quarter of oncology practices sold to the hospitals, and I think the statistics were closer to 50% of cardiology practices. Part of that, again, is the economics. Under the physician fee schedule, we're paid about 2/3 of what the same service is paid for under the hospital outpatient prospective payment system. So a hospital outpatient department can be paid significantly more for the same service. And I think that we will discover in our workforce study, we also looked at the volume of patient care given by a hospital employed physician versus a small business private practice physician. It was about 60%. At a time when we have a shortage, I'm not sure we can afford that. I'm not sure we can afford to pay more for the same service in this time of escalating healthcare costs. I think we really need to look at very efficient mechanisms to rearrange how we deliver that care and go for the most cost-effective side of service.
If I could jump in on that as well. I think we have to be careful, though, because hospitals, along with physicians, if they are collaborating together to do improved outcomes, cut the cost, if what they've got in place is working, we've got to look at that side of the coin as well. So I think this must be a balanced discussion going forward. We have great concerns about this, and I would agree with Dr. McEnany, but we must look at the balance of this, because I think there are some systems out there that are working to make it better for physicians and hospitals and patients, most importantly, to get the job done.
I just add to what my colleague said here is that there's been a major change in cardiology. It isn't everywhere, but in Indiana, 95% of the cardiologists work for some health system or a hospital. There's been a great move. And as best we can measure, a lot of it is due to just the uncertainty right now in finances. You know, it's like if you have a practice, and these are small businesses, is what are you going to do at the end of the year if there's a huge change in physician payments? I saw people in the Detroit area, some physician practices. For instance, when we had a delay in kicking SGR down the road, and there was nothing coming from Medicare, it was like they were worried about paying their staff. They didn't want to lay their staff off, whose husbands may already not have a job and that sort of thing. And they went bare for weeks. And that uncertainty says, maybe I should do something with a little more security to it and be part of a larger healthcare system. So if you want to integrate it all, that's a good way to do it. It's just create a lot of uncertainty. On the other hand, as Dr. Hogan points out, is that when you have doctors and hospitals working closely together, because now you've solved the alignment problem, they will align and try to create better value.
What do we do? We got an SGR problem, right? And it's not very far off. We've got to extend it. Do we just extend it again another year? If we don't, what changes do you suggest? I mean, these are all great ideas. It's fascinating. It's very stimulating, this discussion. We've got a practical question looming. And that is, what do we do about all this in the short term as well as long term? To me, Senator Connell asked an interesting question about more individualized treatment. I guess the question of personalized medicine, all this fancy stuff you read about in the papers, and the genome sequencing and DNA sequencing, and especially the ecology. That very interesting article a few days ago about a lady who got very fancy treatment, specialized cancer treatment, unique cancer, that was rank cured her, and then she died 2 weeks later. But there's stem cell research developments that are going to occur over time. And things are just changing so quickly. So how in the world, what should we do in the short term, and what should we do long term? What should Congress do in the short term and the long term as we deal with this practical problem of extending the SGR?
Mr. Chairman, we've included in our testimony the first bit, the foundational elements of our thoughts from the American College of Surgeons about replacing the SGR. Now, in terms of how to pay for it, I can't go there. That list that
unfortunately we have to go there.
Yeah, yes, sir. But that's a higher authority than I can. So when I look at this, though, what do we replace this? Within this entire context of this discussion we're having today, we're all moving from the volume world to the value world. And we think that's the replacement. And we think it's a patient-centered approach that should be taken. We think you set the updates by setting targets based on value. Did we achieve this value? And it's a patient-centered target. What do we need to do in the 10, 15, 20, 100 measures that we have in surgical care? What do we need to focus on for those patients as targets that then drive an update? And those have to have downside and upside. What do we do in chronic and prevention care that we want to drive improvement with my colleagues in primary care? What are those targets? What do we do across all of cardiac care and set targets? We've got hundreds of measures today, and if you look at the National Quality Forum's measure library, there's over 800 measures in there. Which ones are critical? Which ones are going to be meaningful and actionable and are meaningful enough to you as targets that this is better quality care, safer care, and more affordable care? And let's set those out as targets. and then award the SGR target, replacing it with a value-based target, and make it a patient-centric target. That's our proposal, in short. And what do we need to do in the short run with that? Some initial pilot modeling and how we actually begin it. We're building the alliances across the specialties of medicine to do this. And then how do we roll it out and phase it in? And we have a 4 to 5 year phase-in plan that we think can be implemented with, get some roll your sleeve up work.
Now, is this for surgeons, or this for other specialties as well?
It's for the patients. It's across all patients.
All patients and all care.
It includes rural programs. It includes chronic care prevention programs. It includes, instead of being surgery related, it's patient centered. What is the digestive disease program that we need to improve, which would be gastroenterologists, primary care, and surgeons? What are cancer programs, which is not just oncology, it's radiation therapy, surgeons, and primary care. You can't get away from primary care. They're tied to every one of us. So how do we set targets that actually we can go out to the community at large and say, we have a country of this problem in this area, and we're going to set a target to improve it.
Dr. Weaver?
Just a couple of comments, and I think what you've heard from all of us this morning is, unfortunately, these improvements are going to be iterative. They're going to take time. They're not going to be there on January 1st. I'll give you an example, though, of something that did happen on January 1st of this year in Southeast Michigan, and that is the larger employers changed patient deductibles from very modest numbers to $3,000 or $4,000 per person. I can tell you that the amount of health care that people are getting dropped dramatically. People's co-pays went up. They don't come to see the doctor. They decide when they're going to see the doctor. They decide when they're going to see the doctor, and unfortunately, I mean, it reduces costs a lot, it reduces utilization a lot, but patients don't have the ability to know what is valued and what's not valued in their care, and so they put off prevention. They put off things that ultimately are going to cost us all a lot more. But increasing co-pays, increasing deductibles will change the amount of healthcare dollars that are spent immediately.
Dr. Strain?
You mentioned personalized medicine, and we have this fascination in America with high-tech genomics and things, that one of the most important features of people's health and wellness is having a personal physician, a usual source of care. They get their prevention and wellness, they get their acute care needs taken care of, their chronic illness care, and the way that we're going to save money in the long run is investing in primary care in this patient-centered medical home, and we need to align our payment system to do that. As Senator Campbell mentioned, we don't have enough primary care physicians, and so we need to invest in our workforce, in reforming our graduate medical education system. We're seeing this play out in the private sector with private health plans. The Patient-Centered Primary Care Collaborative is a national organization that's employers and payers and patient stakeholder groups that are really already documenting tremendous success in this direction.
Mr. Chairman, you asked the key question that we ask these people to come here and advise us on. Are you ready to present to us, as the experts, a process, a methodology for payment that we could institute on January 1st with some assurance that the costs would be within a certain range to the federal government and meet the objectives that I think we all agree on here? Or, if you're not going to be ready to do that, then what would you recommend we do? Would you recommend we do an update, a positive update of 1% or 2% with some reporting requirements and phased in pilot programs and so on during that year, so that January 1 a year later we could make decisions about specific payment methodologies that would go across the board? In other words, respond to the chairman's question here. We're going to have to make a decision in 6 months. What do we do?
Dr. McNanny?
Thank you. Again, a very important question. I don't think any of us are prepared to answer that very quickly. This is a huge part. It's a seventh of the economy in healthcare. We're not going to be able to fix it by January 1, 2013. I think a 30% cut will put many practices and many hospitals out of business, and that will cut the amount of healthcare that's delivered, but I don't think that's the intention of any of us. So I think that, again, we're going to need another positive update. AMA data has shown that for the physician fee schedule, we're currently being paid at 2004 levels. The light bill is not at 2004 levels in my practice. I think we need some time and some stability where we can do some pilot projects, because what works, even in my practice in New Mexico, the things that work in my Gallup clinic in the heart of the Navajo Nation are not going to work in my Albuquerque clinic or in my hospital-based Silver City clinic. They're different mechanisms that will be there. The Innovation Center got thousands of people, thousands of doctors wanting to give ideas about how we knew we could save care and save money and giving care. So we would like very much to know that we had some degree of a period of stability where we know we could count on Medicare to not pull the rug out from under our practices and from under our patients, so that we could then work with various pilot projects that can be area specific, part of the country specific, specialty specific, or integrated across multiple specialties to be able to do that. I'm hoping my Innovation Center grant will prove to you that we can take a bundle of payments, take care of patients through a continuum of care and be able to save money. But it's going to take us some time to be able to rearrange this system.
Dr. Oben?
Thank you. Very, very important question. Updates and stabilization, you've heard several now speak to that. I think the question of stabilization for practices is a huge and key issue going forward. There is a huge amount of work out there already underway, Senator Kyle, on these the models, the way we deliver care and how care will be paid for. They are going to be multiple in type, not one size fitting all. These practices cannot endure that because they're different based on the practice, the location, the patient served. So we've got to be willing to say there's probably going to be more than one delivery system. There's maybe more than one payment system to follow that delivery system as well, but we won't know until we do that. One of the things which you all could do now would be to allow physician practices to roll into a model of whatever they choose to do when they're ready to do it, so that there's not a limited window of time. Right now the window opens and then it closes and nobody can get in there and get the work done to get ready for the infrastructure changes that happen. In rural and primary care practices in parts of this country, getting the funding out there to help them get the infrastructure is a key issue. It's got to take place in order for them to be participants. But we cannot expect them to change overnight. But we can get them enrolled in these programs if we provide them the wherewithal to do it and the timing allotment that will do it. The other thing we've got to do fairly quickly is the Medicare data system. And you've heard repeatedly now today, we've got to have the data that we need in order to do the quality work. Physicians want to participate in the quality programs, and in fact, to some of the earlier discussions, the relevance of the measures, etc., being used, the whole issue of the mechanics of the way these programs work, they don't work particularly well for physicians. And then again, another opportunity here is what we refer to as the deeming opportunity, which was in our written statement, which allows physicians who are already participating, like Dr. McEnany's program, in a very high quality program with improvement outcomes, let that count towards this entire issue of physician participation. So those are some fairly straightforward things that could be done on the short term as we get to the final payment and delivery models that we're going to end up needing to use in this country.
What's the Medicare data problem that many of you are referring to? What's the problem? Dr. Mack?
I'm going to give an example that I can use from my own practice.
Sure.
We participated in the PQRS since it was PQRI from the beginning. I'm a fully electronic practice. We've been paperless since 2002. So I know I have data on my practice of what is done. Yet last year, we filled in all the PQRS, and I could prove that I have the documents for each one of those. Yet when I turned it into Medicare, we didn't get any of those updates. They said your data was incomplete. I said, I have my data. They said, no, ours says you didn't do it. So and that's just one small example of some of the flaws in the Medicare system in terms of rapid turnaround for data. If we're going to manage a population of patients in the medical home, we have to have real-time, very good data, where our patients are, what care they're accessing, what side of service they're doing it in, what are their complications, what are their comorbidities, who are their other doctors. We have to have that data practically real-time if we're going to be able to save the system money. But if you get data from Medicare, you get it a year and a half later when it's history. We need it now, so we really need Medicare, CMS as a partner to work with the physicians to be able to feed
What does
data.
CMS say? We don't have the money to update the systems? What's their response?
They're working with us.
So, if I could,
Is there a legitimate reason?
there's this current structure, Mr. Chairman, that the way the data is pulled in and then analyzed, it's, for example, 2012, we're looking at 2010 data. And so how does that become actionable and meaningful when you get your report? It's really just tied to an update in finances and not to clinical care. And we want it tied to clinical care so we can make actionable statements about patients. So that's the problem, using claims data that then has to be aggregated when that year's closed out and analyzed, and by the time it's analyzed and presented, another year's passed. That's why we're looking at other data systems that will get to the target you're asking us to get to. And if we have access to these other data systems, they're real time. They allow us to say, that happened last month. That can't happen this month. We need to put an action plan in place to correct that. But that's part of the big disconnect. And it's not for lack of trying, it's just the wrong data set to drive the goal that we're trying to reach.
The other place you can help us is the private insurers. Their data is much more rapid, but they're not very transparent with their data.
True.
And for us to manage, ideally, we should have anybody's data of those patients that we are trying to manage in order to do it best. It allows us to look at claims data and clinical data at the same time. We're prepared to do that. But it's almost like it's proprietary to some of these to the payers. They don't want to share it with you, and yet they're spending millions and millions of dollars.
I know that's true. That insurance company not long ago, they're showing all this gee whiz technology they have.
Yes.
On claims data. They know everything about everything. And you pull back the screen, you think you're down in Grand Central somewhere. I mean, I asked them, what about outcomes? They weren't a little hesitant on that. Well, do you share that with your hospitals and with your practices? The answer is, well, go pay for it.
And the challenge with the practice is you might have 10% of your population in each of different programs, and then you've got your Medicare data and your Medicaid data, and it's not collated in any single place. They use the claims data because it's what they have, but they really need, as we make the transition to EHRs more broadly in our practices, we need to move to claims data.
I'd like to
to clinical
a
data.
little more, if you could, though. It's a question I asked Senator Connell asked her. Just what do we do? Short-term, long-term. We have to be consistent, flexible in different parts of the country. I think we have some understanding of all that, but we do need some ideas of what to do.
Well, I mentioned in my opening remarks, H.R. 5707 is a bipartisan House bill. I would encourage your consideration of its provisions. I mean, you've heard from all of us the importance of providing some predictable stability in physician payment, particularly for primary care, operates on a much thinner margin, particularly in our small practices. The recurring annual or sometimes multiple times per year potential cliff in payment is a huge stifling factor in investing in practice transformation for this future that we know we need. So this bill has a repeal, it has a positive update, and then it has declines in fee-for-service payments in the later years once we have these new models tested to take the place of pure fee-for-service.
To the specifics of Senator Connell's question, can we have something ready for January? Why it would be a really big push for us to push our model to that point. We're just now trying to sort through how do we actually score this and show you the ability that this has to reduce cost and improve quality at the same time. So in short, I think we're going to need a bridge, but also we could use help from the Innovation Center as to how we're looking at data and how we actually get that data in a meaningful point that would get to adequate scoring in the value-based update model that we're proposing. So there's an opportunity for us to work more closely with the Center of Medicare and Medicaid to actually do the work we need to get the scoring of the modeling so that we can, by that subsequent year, give you a more complete package. And we think it's in alignment with our entire conversation about value and about patient-centeredness. So that we do believe we can do, and we're ready to roll our sleeves up on it, but we could use some help in getting access to and partnering with the knowledgeable side of the Innovation Center and what they could do to add to this.
One of the other things I would throw in on this, and I agree with what Dr. Opelka has said, is the whole issue around care coordination and transition of care. The new codes need to be in place, payment for this. I mean, there's going to be some upfront expenditures. The care coordination is extremely important. You've heard that earlier in our discussions today. It will result in long-term savings, but we have got to get the ball rolling and make it meaningful. We could talk for hours about how folks fall through the cracks. It isn't patient-centered necessarily, although we try like heck to make it so, but we do need help in that particular area as well.
Okay. So, dude.
Thank you, Mr. Chairman. Thank you all for your insights. I want to throw, I know most of you represent more populated areas of the country or work in those areas, but I wanted to just raise an example of some of the challenges that we're facing in rural parts of the country when we talk about SGR reform and financial stability for our healthcare providers. You know, in South Dakota, it shouldn't be any surprise that most of our providers are highly dependent upon government payer sources. Here's an example of one of the towns in my state. This is Chamberlain, South Dakota. It has a population of 2,300 people. Has a payer mix of about 40% Medicare, 20% Medicaid, 20% IHS, and 20% private insurance. And you got 80% of the revenue tied to what tend to be unstable federal payment systems, and they're struggling to keep up with reinvesting in the critical facility upgrades and nursing recruitment and all those sorts of things. And the other point I want to make about that is it's very hard to recruit and retain providers, physicians into some of these rural areas. And I'm curious to know, I'm going to give you another example. We're in South Dakota. We have an estimate that 27% of our population resides in areas that lack sufficient family practice, internal medicine, or OBGYN, which is 48th in the nation. And so recruiting and retaining quality physicians has traditionally been a challenge for hospitals in rural communities. I'm wondering what your thoughts are about the lack of an ability in rural settings to cost shift. I mean, most people in more urban settings cost shift to your private payers, and because the margins are so thin with regard to government reimbursements to physicians, and particularly in the primary care area, how much that is impacting the ability of rural areas to recruit and retain physicians. You got this high amount of the payer mix that is government sources. The cost shifting that many areas can do isn't available, at least not at the same level in some of these rural areas. But it strikes me that that's really impacting our ability in the rural parts of the country to be able to get people to come out and practice. And again, it comes back to the whole point of payment reform and what we can do to incentivize physicians to work in these areas. Just curious if any of you have observations about that. Doctor, I guess the answer is doctor.
Yeah.
I currently practice in a small metro area, but my first practice was in a community of 2,700 in central Washington, 12 miles from the nearest hospital. I understand the problem that you're referring to, and it is largely primary care physicians who are out in those rural areas, and in most practices, even in primary care, only 20 or 25% of their practices is Medicare and a small Medicaid portion, and so it's the measures you described, but upside down. I think what we have to do is, again, realign payments so that it supports primary care and use the innovations that we've seen in the commercial market, which is unfortunately for many of your folks a smaller piece of their business. But in the medical home pilots conducted around the country and coordinated with employers and insurers through the Patient-Centered Primary Care Collaborative and others, showing huge improvements in healthcare quality measures, but also cost efficiencies, and it's the reason that we need the federal payers to be involved in that. It's why the Comprehensive Primary Care Initiative is such a unique, potentially game-changer program for primary care, including in rural areas, because it's a collaborative between CMS and private payers in the local market to pay this blended payment model to support that necessary practice transformation. And we know not only are those practices more efficient and better care, but the people who work there are happier, and that's an important factor in recruiting to a rural area.
Yeah. Thank you, Senator Tim, for that question. I come from New Mexico. We're rural and frontier, so I can relate. In the small towns where I provide oncology services, one is in the heart of the Navajo Nation, another is in the southern part of the state, where the primary care doctors ask us to please provide those services because patients were electing to stay home and die rather than drive for hours to get cancer care, which is just too sad in this country. One of the things that I find is that it actually costs more to recruit doctors, nurses, physical therapists, radiology technicians, etc., to a rural area than it does to an urban area. In an urban area, a doctor who shows up with a spouse, both can generally find a job. In a rural area, often one can't. And we have to work harder and pay more in rural areas. Yet the Medicare system is set up with the geographic price cost indicators, which penalize those of us who have been in rural areas, who have kept costs down, so that when we try to recruit people, we're paid less for someone who costs us more. And one thing that Congress could do is to take a very strong look at the geographic price cost indicators that adjust all of our payments for these rural areas, and look at whether or not they truly still reflect the cost of providing care. I'm an oncologist. If I have to have oncology nurses, I'm recruiting through a national market. I advertise nationally for people to come to Gallup, New Mexico. It's not easy, and we struggle with that. We've set up our own training programs inside the practice to train nurses, to pay them more to become oncology certified. But this is things that we're taking on. Your description of the payer mix is exactly my payer mix in Gallup, maybe not quite as good as what you described. And that practice is losing money, and I'm struggling in a private practice to keep it alive. If the payments were higher for rural and underserved areas and populations with severe health disparities to reflect the increased work it takes to take care of people who are socially disadvantaged, then you would be able to move some of the doctors and nurses and others from the more urban areas into these rural areas, and we desperately need your help with that.
Would the rest of you agree with Dr. McEnany? Pay more for those who practice in, rural areas?
I wouldn't say it's just rural areas. I would say many inner cities have the same problem.
Equal pay for equal work.
Right.
What about loan forgiveness?
I think that's effective. I mean, physicians...
Yes, we do it in Kentucky.
Yep.
Yeah.
Yeah, there's good state and federal programs for that are very successful.
The other point to this question as well is empowering those practices, not just with payments, but empowering them to be engaged in the whole delivery reform process, and that is going to be a challenge. The advanced payment program, so they can get their IT, health information technology, up to speed, is a very important one. The other thing is working on mechanisms for them being able to connect to specialists, other folks, not just in that primary care world, but the specialists they need to help them manage their patients. And I think we could do a better job in working out systems to allow that to happen, so that they get the support, they don't feel like they're hung out to dry, in eastern Kentucky, from where I'm from, and that they can provide the care they really want and are able to do.
How much EMR interoperability is there with facilities?
That's a huge issue, a huge,
Almost none.
painful issue. There's not.
It's more like an oxymoron.
Yeah, there is no
So
interoperability.
that was one of the things that we were addressing and getting better at. I mean, and you know, people come in, experts, and testify that that's not happening.
It's not happening.
Well, what we're seeing, what they're saying and what we're seeing is just completely opposed. Even within the same vendor, where there's a vendor who version 1.1 and then this institution over here is version 2.2, they don't talk, even within the same vendor. So there's a major barrier there.
So how do we incent getting them to work better together? I don't think much is going to change until they get proper incentives, the vendors.
Well, you know, I think there's a lot going on from ONC in this effort to try and set data standards and try to move more consistent data across all these areas. Again, the initial move of getting the EHRs out there was, let's get everybody digital. And now we've got to get digital communication. We've got to get the movement of data. And then we've got to get the meaningful movement of data. So ONC is now at the point of data-to-data movement. And their next step is, how do we get to meaningful data? We're the context experts who can give you meaningful data. We need to have the ONC standards go out there and say, we'll get you movement of data, and then we can front-end load that with content and context. That will give us actionable data.
The other area you can help us with is, I mentioned before, criteria for like appropriate use of testing and that sort of thing, which could decrease utilization. That's done on the side right now. It's like it needs to be a workflow. It needs to be in the EMRs, and the EMR vendors aren't stepping up to incorporate that kind of thing. And that's where we'll see changes occur, when we don't have to pay extra to collect the data and distribute it versus having it part of the EMR.
Maybe we should have the vendors here.
Maybe.
Might help.
Yeah.
Talk to them about this with you here.
We actually had a meeting with them 2 days ago over at the IOM, and to this